Hi, I'm Dr. Brar, board-certified family medicine physician and certified menopause provider. Not all estrogen replacement is the same. The source of the estrogen matters and the route of delivery matters too. There are two kinds we mainly use. Conjugated equine estrogen is derived from pregnant mare's urine. The classic example is Premarin. And bioidentical estrogen, which usually refers to estradiol, meaning a hormone that is chemically identical to the estradiol made by human ovaries. There are FDA-approved sources of bioidentical estrogen, so this does not just refer to compounded medications. Conjugated equine estrogen has a long clinical history and is FDA approved for menopausal vasomotor symptoms, vulvovaginal atrophy, and prevention of postmenopausal osteoporosis in selected patients. Because it has been used for decades, we have a large amount of safety and outcomes data on it. It was also the type of estrogen used in the WHI study we talked about in the last video. Bioidentical estradiol is often favored today because it is molecularly identical to the main estrogen produced in the body before menopause, and it comes in many delivery forms, especially transdermal options like patches and gels. Oral estrogen was the traditional starting point for many years. It is convenient and familiar, but because it is swallowed, it goes through the liver first. That first-pass liver effect can increase production of certain proteins and is one reason oral estrogen is associated with a higher clot risk than transdermal estrogen. When might we use oral? So if a patient prefers a pill, if there's a cost or formulary issue, if there's no strong clotting or triglyceride concerns, and if a patient is comfortable with daily oral dosing. Possible downsides of oral include that it's first pass liver metabolism, there's higher clot risk compared with transdermal, and in many patients it can be less attractive with high triglycerides and liver concerns. Next, we have transdermal estrogen, which is your patches, gels, sprays, and creams. Transdermal estrogen was a major advancement because it delivers estradiol through the skin and largely bypasses first pass liver metabolism. That gives us steadier systemic estradiol levels and for many patients, a more favorable clotting profile compared with oral estrogen. When transdermal may be preferred, if there is a higher concern for that clot risk, migraine or sensitivity to hormonal fluctuations, elevated triglycerides, if there's a preference to avoid daily pills, and a desire to avoid that first pass hepatic metabolism. Potential downsides include skin irritation with patches or adhesive issues. Gels and sprays require correct application and drying time. Insurance coverage can sometimes vary. It is important to note that generally speaking, these days we prefer a transdermal approach rather than oral since it's lower risk. But again, this requires a risk-benefit talk with your provider and an individualized approach.